this case, we're thinking about doing some handheld dynamometry to kind of get a good retest on our patient's hip abductors. From this case and her subjective and objective examination, we are aware of the fact that her hip abductors are weak, secondary to pain, and also to just some general weaknesses that she's having. So the way that we would do this is we have the patient sideline on her left side with the right leg up. We would instruct her kind of maybe bend under this leg for more stability, keeping this leg straight. We'd start out by just kind of instructing her on what the movement's going to be, seeing if she can get that active range of motion. So we're going to emphasize keeping the hip forward, the leg back in extension a little bit, and kind of these toes pointing straight towards the wall. Perfect. And then, Allie, can you bring your leg up towards the ceiling for me? Good, perfect. So she gets that good active range of motion, you can relax. Then we pull out the nice dynamometer, power it on. We know that when we're testing hip abductors, the further distal we go, the longer the moment arm is going to be, the harder the test is going to be for the patient. Since we got a pretty low-level patient, secondary to pain and the weakness that she's having, we're going to test it more proximal, right above the knee. As long as we stay consistent with that in our retest, shouldn't be a problem. Also good to make clear that we would also be testing the left side as well in the same way, just so we can compare both sides and see what we're working with. So we went through the active range of motion, and now we're going to have the patient go through that active range one more time. So Allie, bring that leg up towards the ceiling. And now I'm just going to take the dynamometer right above, kind of proximal to that knee. I'm just going to say, Allie, I want you to hold it here. Don't let me push you down. Ready? 3, 2, 1, go. Good. So I really couldn't break her that much. I was pushing with all of my might. She got 56.3 pounds of force. So now we can do some interventions. She said, ow, that was a little bit painful. We'll do some interventions, some joint moves, some exercises. We'll retest this and see what we get. So the next thing that we can do, we also know that hip internal rotators are often weak in this hip osteoarthritis population. Sometimes they're weak just because of actual general weakness and not enough use, or sometimes they're weak secondary to pain, which are both important things that we want to see. So in order to test the hip internal rotators, we have the patient in sitting. I would ask the patient to, can you bring your foot out to the side, please? Good, right, so she gets that good active range, you can relax. And then I just kind of put the dynamometer on, turn it on. You want to come over here? I would turn it on, and then I would be putting the dynamometer on the outside, just kind of right above that lateral malleolus, right? I like to stabilize right here at the medial knee. And then I would say, all right, can you go through that same motion, right? She's pushing into me, I'm pushing into her as hard as I can, and then we relax. And get a good reading. So she got 38.5 pounds, but a good important question to ask with the osteoarthritis patient is, was that painful?
Yes.
And it was painful, so now it's important to also test that in comparison to the left leg, see if there's any measurable distance, do a couple interventions, do a retest, and see where we are. So we just tested the internal rotators, and now we also want to take a look at our patient's external rotators, because from her case, we know that she kind of has that right lateral lean, that Trendelenburg classic sign. So when you have weakness in the hip abductors, it's often common that those patients also have pain, weakness in the hip external rotators. So the way that I would do this is have the patient in sitting again with the feet hanging off the edge of the table. This time I would ask her to bring the foot inwards towards the other one, right? So she gets that good active range, always monitoring the patient for pain, asking for response.
Ow.
So she said that hurt. So let's see what happens when we add a little bit of force on it. So you turn the dynamometer on, this time right above the medial malleolus, stabilizing on the lateral knee, and then asking her to go through that same motion again while I'm pushing. Right, so a little bit weaker on this than her internal rotators actually, and she's getting 20.7 pounds. So then I would compare that to her left side, see how that feels, pain, weakness, anything like that, and then we do some interventions, some joint moves, different types of exams, and then we see where we go from there.